All right. Well, I have 12 o'clock Eastern right now, and I know, as always, we have a jam-packed agenda. So I'm Lindsay Browning. I am Director of Medicaid Programming at the National Association of Medicaid Directors. Really excited to host today's Crisis Jam. And as I was saying, for those of you who joined a little earlier, today's going to be our Medicaid Bonanza. We're going to hear from Nancy Kirchner at CMS around some of the crisis opportunities for Medicaid. So really excited to lead that conversation and hear from Nancy. So next slide. Just a quick reminder of who all is participating. We have robust, incredible participation in these calls every week. I think David mentioned that last week, over 50 people were added to the newsletter, which is awesome. But if you don't see your organization listed on here and you're joining these calls, please let the team know so that we can get you represented, including if you're from Medicaid. So here's the website where you can find all the resources and sign up for that newsletter. It's talk.crisisnow.com. And you can see the featured presentation from the week before on there as well. So make sure you're checking that out and spreading the word of that resource to your team. Next slide. Just a couple of news items before we jump into the featured presentation today. The first is that there is the first ever Youth Mental Health Forum happening at the White House today. And I think at least one of our regular Crisis Jam participants is there participating. So we're excited to hear more on a future call around how that went, but an important event happening today. The other news item we wanted to share is a piece of news out of San Diego County around mobile crisis and 911. So we just want to play a quick clip of that news for you all about how they're sort of linking those two systems. So David?
As of Monday of this week, all 11 law enforcement agencies in our region now have a system in place to refer a non-emergency mental health call into 911 to the mobile crisis response team to get that individual the right type of help that they need.
We're learning. We have lessons learned. We are applying them as we move forward. We are very nimble and flexible, and that's how we created the program, so we can adjust in the midst to be responsive with our community and our clients, because that's ultimately who we serve, right? The clients. So we will apply those lessons learned and tweak the model where we can and need to be the best program that we can be here in San Diego.
Last year alone, San Diego County law enforcement responded to 38,380 calls for service for mental health related concerns. That's an average of 105 calls for service per day.
So you can see there the connections that San Diego County is making that many of us are working on between the 911 system and the mobile crisis and 988 system. So really excited to see those connections being made and really operationalized in an incredible way. Next slide. But of course, the reality that we're all grappling with is capacity, right? As these calls come in for crisis services, making sure we have the capacity to respond. And that's what today's quote of the week from Dr. Rochelle Head Dunham is about. The quote is, "We're often more restrictive than accessible with our crisis services, but it's frequently because we lack the capacity to meet the community need." So all about kind of building that capacity and removing restrictions so folks can access those services. Next slide. All right, so with that, I am thrilled to move us into our featured presentation for today. Nancy Kirchner is a technical director at the Center for Medicaid and CHIP Services at CMS. She has been at CMS since about 2007, and prior to that was at the Maryland Department of Health. So Nancy's going to tell us all about Medicaid Crisis Opportunities, and then we'll have a bit of a conversation. So Nancy, I'll turn it over to you.
Thank you very much, Lindsay, and thank you very much, everyone. I was here for kind of to get my toe in the water at the Crisis Jam a few months ago to talk about crisis, and I am delighted to come back and do a little bit of a deeper dive on Medicaid and crisis opportunities. If I can move to the next slide, please. All righty. So in Medicaid, there are various kinds of coverage opportunities for community-based emergency and mobile crisis response and crisis intervention services, as well as a wide range of other mental health and substance use disorder assessment and treatment services and items. These paths for Medicaid coverage include the mandatory and optional state plan services, such as physician services, other licensed practitioners, medication-assisted treatment, prescribed drugs, rehabilitative services, and that includes peer support services. Additionally, other Medicaid authorities can be used, such as the 1915I State Plan Home and Community-Based Services Benefits, Section 1915C Home and Community-Based Waivers, and Section 1115 demonstration programs. CMS has also issued 2 state Medicaid director letters on opportunities to expand the substance use disorder and mental health systems. The first one is strategies to address the opioid epidemic and opportunities to design innovative service delivery systems for adults with serious mental illness or children with serious emotional disturbance. And those 1115 demonstration opportunities have been available since 2017 and 2018, respectively. And those allow states to cover and receive federal financial participation for various pieces in the mental health and substance use disorder service continuum that include residential crisis receiving and stabilization facility services, and also ongoing services to prevent future behavioral health crises and avoid inpatient psychiatric treatment. Also, the American Rescue Plan Act of 2021, Section 9817, provides state Medicaid agencies with a temporary 10% percentage point increase in their federal match money for certain Medicaid expenditures for home and community-based services. And certainly while the focus has been on some of the kinds of services often provided in 1915C waivers, this offers an unprecedented opportunity for states to collaborate and expand, enhance, and strengthen their behavioral health services in order to prevent crises and provide continuing support during recovery. Can I have the next slide, please? All righty, we're going to shift the focus to a newer provision that is creating a lot of buzz and excitement out there. Certainly, I'm excited to talk about it. And that is Section 9813 of the American Rescue Plan Act. CMS issued guidance on this particular provision back in December of 2021. SAMHSA was a very strong collaborator and partner with us on issuing this guidance, helping us to flesh out information about best practices and resources for states on mobile crisis, how to establish mobile crisis services as part of a continuum of care, and including how to incorporate into the new 988 National Suicide Prevention Line and connections with CCBHCs. The guidance offers links to resources to assist with approaches to link individuals to needed services in order to avoid emergency department use and hospitalizations. And we also believe that most mobile crisis teams, as you saw in the clip, can help responses for crisis, not including law enforcement, except in special circumstances that would require their inclusion. We also do a real shout out around the important role that peer supporters can have as paraprofessionals on a mobile crisis team. And we also talk about the importance of partnerships with schools, after-school programs, courts, foster care, the justice system, and many other groups. We think that states using qualifying community-based mobile crisis intervention services will help use trained mental health professionals rather than law enforcement as first responders. We also believe that it has the potential to divert individuals into appropriate and timely care and treatment rather than in and away from the criminal justice system, as well as that more costly inpatient care. Section 9813 adds a new option. So this is optional for states for qualifying community-based mobile crisis intervention services. It amended Title 19 of the Social Security Act, which is where the Medicaid programs are. And it does not, however, add a new benefit in Medicaid. It basically talks about the different kinds of Medicaid state plan options, as well as other authorities through which these kinds of services can be provided. And the main objectives of community-based mobile crisis intervention services are to provide the rapid response, individual assessment, and crisis resolution outside of a hospital or other facility setting. And it's specifically for individuals that are experiencing a mental health or substance use disorder crisis. The team needs to be able to provide services when appropriate that include screening and assessment, stabilization and de-escalation, and coordination with and referrals to health, social, and other services. This state option is available. It started April 1 of 2022, and it's available through March 31st of 2027. Next slide, please. So why is this important to stakeholders and state Medicaid agencies? I already told you this doesn't create a new benefit in Medicaid. What it does do is for the first 12 fiscal quarters that a state is providing these services under an existing authority and meeting the requirements in 1947 of the Social Security Act, states may receive an 85% federal medical assistance percentage, or FMAP. So that is a higher level of matching federal funds. And it can be done through the state plan, as I mentioned, 1915B waiver with corresponding authority, 1915C waivers, or a section 1115 demonstration. So there's lots of different Medicaid authorities the services can be provided to. But I've actually heard some folks refer to this particular provision as the mobile crisis increased money, or increased FMAP, rather than a new benefit. Next slide, please. Okay, so these services and provider qualifications. Under this particular provision, services have to be provided to an individual who's Medicaid eligible. So this does not go outside of the Medicaid realm in terms of people having crisis. And we certainly understand people who are not necessarily Medicaid beneficiaries may be in a crisis situation. It's specific to Medicaid. The services have to be as I mentioned, to a person that's experiencing a mental health or substance use disorder crisis. And it also has to be provided outside of a hospital or other facility setting. This is very important. It cannot be provided in an emergency room. An emergency room is part of a hospital. So just clarifying that that does come from the statute. Next slide, please. Okay. Multidisciplinary team. Services have to be provided by a multidisciplinary team. States have tremendous flexibility in terms of what that multidisciplinary team looks like, but a team means more than one person. States can have more than two people, but it has to be a minimum of two. It has to include one behavioral health professional who can conduct an assessment within their under state law, within their scope of practice, but states have flexibility with that. And other professionals or paraprofessionals that have experienced expertise in behavioral health care. So states have a lot of flexibility in terms of who that second member of the team can be. They have to be trained in trauma-informed care and de-escalation strategies and harm reduction. And they have to respond in a timely manner, but that timeliness standard is established by states. The statute and CMS in our guidance did not put a specific parameter in terms of timeliness of response. Next slide, please. So what do the teams have to do? They have to provide screening and assessment to the individual where they're experiencing the crisis. They have to stabilize and de-escalate, and then they have to coordinate with and provide referrals to health, social, and other services and supports. So someone may be moving on to higher level of care. It may be that the situation can be stabilized. It may be that they need to provide additional referrals and follow-up for the individual that they're going to need to be doing afterwards. These mobile crisis teams need to maintain relationships with relevant community partners. They have to maintain privacy and confidentiality. And mobile crisis is an important component. Mobile crisis intervention services have to be available 24 hours a day, every day of the year. So having mobile crisis that's time limited only to particular times of the day is specifically precluded by the statute, and our guidance does address that. Next slide, please. So so mobile crisis intervention services can be delivered through either a fee-for-service payment arrangement or through managed care. And we do go over all of that information in more detail in our letter. If a state is going to be providing it through fee-for-service, they're required to have payment pages in their state plan to do that. For managed care delivery systems, there still has to be an appropriate Medicaid authority to deliver the service, and then the services have to be specified in the managed care contract. Next slide, please. Maintenance of effort. The statute does require maintenance of effort, that additional federal funds for the qualifying community-based mobile crisis intervention services must supplement and not supplant the level of state funds expended for the services in the federal fiscal year prior to April 1, 2022. So that would have been as of the end of September 30th, 2021. There are states that have been covering mobile crisis services. So basically what we're saying is you can't be reducing mobile crisis if you've already been covering mobile crisis in Medicaid. And there are more specific details about how states implement the maintenance of effort requirements in our state health official letter. Next slide, please. Okay, administrative claiming. We provided information in our state health official letter that federal administrative match may be available for Medicaid agency costs that are associated with establishing and supporting the delivery of community-based mobile crisis. So not the services themselves, but the activities that would be necessary to do that for people with mental health or SUD. And some of the allowable administrative activities could include operating the state crisis access lines and dispatching mobile crisis teams to assist the Medicaid beneficiaries. There was a particular presentation on January 25th of 2022 that went in more depth on the administrative claiming opportunities. The link that is there on Medicaid.gov in this particular slide links to the slides that were used for that presentation if you want to find out more about administrative claiming. Next slide. Okay, states that want to add community-based mobile crisis intervention services or need to make changes if they're already covering mobile crisis services, but they want to go ahead and flesh out their benefit or their payment or something in their service delivery system to comport with the requirements in Section 1947, would need to submit either a state plan amendment if they want to make those changes in their state plan, a 1915C waiver application, 1915B waiver with the corresponding coverage authority, or 1115 demonstration. And in our guidance letter, we talk in a lot more detail about how states, what states would need to do to make those kinds of submissions. And states because again, this does not provide a new benefit, but allows states to use existing authorities. States would have to follow the processes for the Medicaid authority that they've selected. And I just want to mention that CMS, as always, stands ready to provide technical assistance to states that want to either implement mobile crisis, kind of brand new, whether they want to make changes to existing authorities in order to do mobile crisis, whether they have questions about what they need to do. We have been working very, very actively. I've probably been on about 50 technical assistance calls since we've released the guidance. And I know other colleagues of mine that are subject matter experts in other areas related to mobile crisis have also been providing technical assistance to states. We have 20 state mobile crisis grantees, and we've been working very closely with them collectively and also individually, but all other states are welcome for this. And so we certainly welcome that opportunity to engage with state partners. And the next slide, I think, is the last slide, and that is just on questions. So I'm going to turn it back over to Lindsay.
Great. Thank you, Nancy, so much for providing that information. I know Dr. Ward is not with us, but Tom, one of our fellow Medicaid gurus on this call, is teed up for a roundtable. And Tom, I know you're only with us till past, so I'll let you jump in first. And then Nancy, I got a couple of questions and comments as well. So Tom.
Thanks, Lindsay. It's great to see you. Last time I saw you, I was climbing out of the north rim of the Grand Canyon, and you were already there and well rested because you got out about 2 hours ahead of me. So it's great to see you. That was a wonderful hike. Nancy, thanks so much for the presentation and information. It was great. There's just so much out there in terms of new opportunities for states in the Medicaid space and how they think about their crisis system and how to really partner with Medicaid around being a resource to help support the crisis system. I thought your comments around the existing authorities, oftentimes people, I think they think about crisis services, and I have so many conversations where people want to talk about 1115 waivers and things like that, but there's already so much in the way of existing authorities within the state plan and other avenues by which states should look to or could look to as it relates to supporting crisis infrastructure. One of the questions I had for you, Nancy, was there's this, you talked about flexibility, which I think is important in terms of timeliness and staffing and states having to make a decision around system design, and I'll come back to that in a minute. But there's this sort of expectation in Medicaid around statewide-ness. And I think back to how mobile response started in Arizona, and it really started in the urban areas first, with different expectations, ultimately rolled out to the rural and frontier parts of the state, and with different, timeliness requirements and things like that. So how does CMS think about mobile response and sort of the statewide-ness requirements as folks think about their system design?
Thank you very much, Tom. And you actually pointed out a really good point that I probably should have pointed out when I was talking about that. In the statute, there are notwithstandings in the beginning of the statute that allow for states to restrict and not to provide statewide, not to provide within the requirements of comparability, to limit free choice of provider, and then also provider enrollment arrangements. We have certainly heard from a number of states that are looking to go ahead and kind of bring this up more gradually. What I will say is that the 12 quarters of increased FMAP that are available during the 5-year period are only one bite at the apple. So I think states are looking at making important sort of decisions around when they start claiming the enhanced FMAP to try to maximize that during that period of time. But states do have the flexibility within the provision to bring it up, but I think they may want to consider when they claim for the enhanced FMAP.
Yeah, I think that's a great point, Nancy. You talked about the technical assistance that CMS is providing to states as well, and that's so important as states look to leverage these new opportunities. I'm curious sort of what you think some of the major challenges are that sort of percolate to the top as you have these technical discussions with states. You said you've had over 50 or around 50. I'm just sort of curious, as states sort of think through this, what are the top 2 or 3 challenges you're seeing on a consistent basis?
I think what you just talked about in terms of that issue is statewide-ness. I think being able to provide services 24/7, particularly with workforce shortages, is something that we hear coming up time and time again. I think there are, for a number of states, a significant enough number, the intersection with CCBHCs and how all of that's going to work. And I know fiscal colleagues in CMS are working closely on that issue. I think also the lines between when is follow-up appropriate under continuing under the mobile crisis rubric that gets the increased FMAP, and when are you really moving into a different phase of care, whether someone's moving on to maybe a higher intensity care, maybe moving on to some sort of crisis stabilization, or whether they're just sort of moving back into the routine behavioral health care follow-up, and the crisis has really sort of been resolved for the moment. Those are some of the areas that I hear percolating up.
Great. That's really helpful. I know, as we thought through this in Arizona and how best to partner with Medicaid, one of the areas that we had to continue to think about from a system design perspective is, Arizona's managed care, so we built on that platform. But it was, what are we going to do to cover those individuals that aren't enrolled in Medicaid? We still wanted to have that type of mobile response infrastructure available, coordinated through the crisis call centers, where crisis call centers could then, go ahead and have mobile response teams go out into the community, but not everybody was going to be enrolled in Medicaid. And so thinking about braiding of funding is just as critical, I think, as states look to not only the authorities within Medicaid and how to best partner with Medicaid, but thinking about the fact that there is going to be some percentage of the population that is not Medicaid. And so what different funding sources, whether it's the block grant funding sources or local sources, can come along as a way to sort of allocate across the different populations that are being served. Because what we've experienced, at least in Arizona, is the fact that to have a crisis system means that you're serving everyone as part of that overall infrastructure, so that you don't have duplication, or you don't have just the challenges of saying this person is or is not Medicaid. And I would bet that's another challenge states are thinking about as they develop their system design around this.
Thank you.
Thank you.
And Nancy, we got a question in the chat that maybe you can speak to, asking if you can speak to allowable use of telehealth in mobile crisis and any flexibility for metropolitan and rural areas.
Thank you. That's an excellent question. One of the things that we've said is it can't be mobile crisis if it's exclusively provided by telehealth, but we recognize that telehealth is an important technology and service delivery mechanism for delivering Medicaid services. So if one of the mobile crisis team members is on site with the individual experiencing the crisis, and they're linked in to another mobile crisis team member through telehealth, that is acceptable under this particular provision. But it cannot be a circumstance, we've said to states, it cannot be a circumstance where the only option for an individual experiencing crisis, regardless of whether that was appropriate or not, is just to get telehealth services.
Got it. And Margie, you had a question as well, and maybe you can just hop on and ask it, because I want to make sure I'm getting this right. I think you're talking about state legislation, or are you talking about federal legislation?
Yeah, there's some of the federal bills that are going around that have sections on crisis. I know that some of the congressional offices have been having back and forth with CMS on some of the specific language, and some of the crisis stabilization language has things in there like, and must be licensed as a subacute, or there's some stuff going around that is specifying that things need to be for voluntary patients only. And so I was just wondering if you had been involved in any of that and were able to say anything about CMS's opinions on those things.
I'm sorry, but I don't have anything to share on those particular points. I know that there has been tremendous recent interest across the crisis continuum, but I'm sorry, I don't have any more information about that.
I think it's an interesting reminder, Margie, that, you know, there's active conversations going on in Congress about behavioral health, right? Behavioral health legislation, sort of while this work is rolling out on the ground. So good for this group to stay plugged in and involved in all that, all those conversations as well. Nancy, I have one more question for you, maybe to wrap things up. I know states are always looking to their peers to borrow and steal ideas and spa language and all that sort of stuff. So was curious if any states have gotten their spa approved yet. And if not, I think we would love for you to come back and tell this group when they do, so that other folks can borrow and steal. So kind of a two-part there.
Oh, actually, so since the provision just went live April 1 of 2022, and states can submit state plan amendments to preserve an effective date to the end of the quarter, I am thinking that we're going to be getting more coming in by the end of June. I will tell you that one state has been working with us on a draft SPA. I'm not going to go ahead and mention the state, but they have been working very closely with us on that, and we certainly are aware of a number of states that have absolutely said that they're going to be submitting state plan amendments, but we don't have any that are approved yet, and we do not have any formally, and this is inside baseball for Lindsay, we do not have any formally that are on the clock or have been formally submitted to CMS yet, but we are looking for that to be coming soon.
Great. And for the Medicaid folks who are on the call today, and if you're coming to NAMD's upcoming state-only meeting, we're going to have a breakout session on mobile crisis. So you guys can share ideas and bat around in the weeds on the Medicaid mobile crisis. So that's great. Nancy, well, thank you so much for sharing. It's really helpful to hear sort of the parameters and ways that Medicaid can play a role as 988 goes live and as the need increases for those mobile crisis services. So appreciate you taking the time.
Lindsay, can I just offer one clarifying comment? There's a comment in the chat about states already have the authority to do this. And yes, that's true. But Nancy, just clarify, if a state wants to get the enhanced match, they need to come back and get another state plan approved, or they can just use the existing authority they have. Can you provide clarity on that, please?
Yes, that's an important point. A state that already meets the requirements in 1947, they can begin claiming. So there is a possibility that we wouldn't necessarily even need to see anything. Most states have indicated that they think that they're going to need to make some tweaks, but they wouldn't have to if they already have the authority to do it. They could begin claiming. So that it could be that we wouldn't know until the time for claiming that someone is already doing it. Thank you. That's an important clarification, Tom.
Thank you.
Great point. Awesome. Well, thank you so much. Really appreciate the presentation and the discussion. We're going to go ahead and move into our trivia segment for today. Leanne Fitzpatrick is in the hot seat. So Leanne, thank you for doing this. So the trivia question today is about branding, since last week was all about SAMHSA's effort around branding 988. So SAMHSA has published 4 icon word pairings, visuals with text around 988. Mm-hmm. Which of the following is not one of the combined visuals that's been authorized for use by SAMHSA in their branding? So the options are Be the Lifeline, Talk with Us, What's Your Story, or There Is Hope. And so we put up a poll question so you can get some help from the audience.
Okay. Yes, I'm Leanne Fitzpatrick with Kentucky Medicaid Services. I am the project director for our mobile crisis planning grant, and I'm on the state implementation team for 988. So awesome. I think I know the answer because I have looked at this several times when it first came out, because I was very anxiously waiting for it. But what is the poll saying? Okay.
So the poll is saying that C is not the combined visual.
Yes, and that's what I thought it was. So I'm going to go with C, final answer.
Awesome. All right. And let's switch to the next slide and we can see what the correct alternate is there. Yeah, good job, Leanne.
Right. Thank you.
Share your thoughts as the 4th visual that they shared. So good job.
Thank you.
Thanks, Leanne, and hope all is well in Kentucky.
Yes,
Kentucky.
thank you so much.
Awesome. Well, I want to move us to the crisis talk and turn it over to Stephanie Hepburn. Stephanie?
Thanks, Lindsay. Yeah, so this week I spoke with Alexandria Robinson Jones, and she's the Behavioral Health Marcus Alert Program and Training Coordinator at Virginia's Department of Behavioral Health and Developmental Services. It was a really exciting conversation. So Alexandria, I'm so excited to have you on to talk about an actual statewide 911 call diversion matrix. We've heard from communities that have started scaffolding this, but to hear a statewide one is very exciting. So Alexandra, can you tell us a little bit about the matrix?
Sure. So thank you, Stephanie. We developed the 911 matrix here in Virginia as a part of our overall Marcus Alert law. So Marcus Alert, it requires 911 and law enforcement and behavioral health to all come together to essentially create a plan to divert folks experiencing behavioral health crises away from the criminal justice system. And so this 4-level triage framework, it really serves multiple purposes. It's a tool to have easy communication across the sector. So since we're bringing together those behavioral health, law enforcement, and 911 communities, it's easy just to talk about level 1, level 2, level 3, and 4, and that's standard across those sectors. It also allowed us to outline minimum standards and align a range of response options with each of those levels. For ongoing evaluation purposes, being able to just have it aligned with just 4 levels makes it easy as well, but it's also primarily used as a triage system that focuses on how urgently a response is needed.
Can you share a little bit, communities, it's a little bit easier for them to scaffold this type of matrix. Can you talk a little bit, just very briefly, because we want people to read the article, very briefly about some of the flexibility that has to be infused in a state plan?
Sure. So with the matrix, we only have 2 requirements for localities that are implementing this. So for the first level, that's going to be your lowest level of urgency. Those calls are required to be diverted from 911 to 988. And for the 4th level calls, which is the most emergent, those are required to have an active rescue response. So for levels 2 and level 3, there is flexibility on what the response can be. For level 2 situations, there is a need for some clinical intervention and to reduce the advancement of greater risk for those calls. And so localities, as they're implementing the Marcus Alert, they're going to have a wide range of resources available, like most states, where it's not consistent across the state. We have locally funded teams, such as co-response teams with law enforcement and behavioral health clinicians, or EMS and behavioral health clinicians, but it varies across the state. So that's why we made it so there's some flexibility, because this is a statewide plan. We needed to make that an available option for localities.
The article fleshes out each level, so you can go there and read more. Alexandria, we're so happy to have you on the call, and this is such an important topic. Thank you.
Thank you, and I'm happy to answer any questions via email, and I will put my information in the chat. Thank you.
Thank you so much for sharing that. I think your point around creating a common language is something that is so critical. Often we're looking for a tool to apply to action, but even being able to speak from the same song sheet is so critical. So great to hear what you've done. And I know there's rumor going around that we may have you back to share in more depth in the future. So thank you so much, Alexandria. Awesome. So we're going to go to the SAMHSA update next. John, I believe you're going to take this one.
Yeah, thanks, Lindsay. And I'll do part of it and then hand it off to Richard for our team SAMHSA update. And great to see Alexandria. We were colleagues a few years back, and great to see all the work that she's doing and everything that's happening in Virginia. Very exciting. And Lindsay, thank you for flagging the White House mental health event and the promotion around youth mental health services and the overall prioritization that the White House has placed on mental health and substance use concerns as part of the Unity agenda. I think that's a really important piece of the federal government's commitment to this work. So as we are approaching July, we all know that there is a lot of work to be done. We're all working with great urgency, and yet also recognizing that this is going to take some time to get to our aspirational goals. We are a few weeks now post release of the funding for states and territories around 988 local response, and are working very engaged with those grantees around implementation support and technical assistance around 988 system development. Also very closely engaged with Vibrant, who are working extremely hard in the run up to July to support enhanced operational capacity and continuing to advance readiness with respect to 988 implementation. A few things that I'll just highlight within that conversation. One is new piloting of local routing for text and chat. This is a really huge step. As we've talked about many times before, we are very much focused in on that local capacity piece, and the system historically has routed calls locally, but not texts and chats. And so there is movement in that direction with a recent pilot, and very excited about how that will progress to support local response capacity across all forms of communication. Also ongoing work supporting the LGBTQ plus training and access enhancements that are part of the FY22 appropriations. So there'll be more to come on that specifically. And then also just wanted to flag again for everyone on the call, the geolocation forum that's happening in collaboration with the FCC next Tuesday, May 24th. And then finally, also just want to re-up the landing page that we have on the SAMHSA website that is an aggregation of all of the call centers, crisis centers that are part of the Lifeline network, supporting visibility to potential volunteer and job opportunities, links to those crisis centers for individuals who may be interested in employment opportunities there. I've personally been getting lots of calls from people who are interested, so I'm very happy about that. So I feel like it's been a good strategy to raise visibility and awareness of this opportunity. And then I'll hand it off to Richard for some additional updates.
Thank you very much, John. So two things I would mention. First, I want to thank Nancy Kirchner for her excellent presentation on mobile crisis. The omnibus appropriations bill did give $10 million additional dollars to SAMHSA to support mobile crisis services and crisis partnerships. And Nancy was kind enough to take a look at that for us, which we very much appreciate, so we could continue to maximize alignment between SAMHSA and CMS in this area. We're hoping that that grant opportunity will be coming out soon, so keep your eyes open for that, and we'll certainly share that with the folks on the Crisis Jam as soon as it comes out. And then the other thing that I would mention, and I think this is very relevant to what we just heard from Virginia regarding their matrix for 911 diversion, is that this is an area that SAMHSA is working on intensively now. And the issue of what calls should go to 988, what calls should go to 911, or which ones can be transferred back and forth and in what kinds of circumstances. One piece of that, that will be upcoming, is a policy academy in June that SAMHSA will be doing for 5 states, focusing on this issue of 988, 911 coordination. The states are Maine, Georgia, Colorado, Minnesota, and California. And then finally, a reminder that coming up on May 24th, the FCC will be holding their forum on geolocation. It will be live streamed, so anyone who wants to watch the proceedings is more than welcome to do that. So thank you, John.
Richard, one quick follow-up question for you on the Policy Academy on 911 and 988 coordination. Do you guys plan to release any of the learnings or insights from that with the broader group of states?
Well, that would certainly be our hope, that what we learn from these 5 states and from these conversations during the Policy Academy will help inform work with other states. So we have not determined a precise vehicle for that yet, but that is certainly our hope.
Great, thank you. All right, next we're going to go to the NASHPIT update. So Megan, I think you're taking that today.
Great, thanks, Lindsay. More than anything, I really want to acknowledge and thank SAMHSA for their excellent leadership on all these areas, and just how SAMHSA keeps things moving, expands, explores, and really is providing so many resources to the nation. I wanted to also highlight the playbooks, and we've talked about the playbooks before, but what we're learning from talking with states is that they really are using them for planning, for technical assistance, for ideas, really getting together as groups and coalitions around them. So I encourage that. NASHPIT encourages that. And so please check these out. And we hope that they're helpful to you. Also wanted to highlight that on June 22nd, Holly Ryu, who provides deaf mental health services in New Hampshire, will be providing a presentation on deaf crisis services from a provider perspective. And I just want to highlight the special and specific needs of the deaf community and how important it is to have ASL fluent counselors rather than interpreters. So, so look forward to all of you being on there. Thank you.
Great, thank you so much. Joanna, we're going to go to you for the federal update.
Yeah, so we have a lot of great action at the federal level right now as we speak. Currently, the House Energy and Commerce Committee is, I believe, as we're speaking, going over the Restoring Hope for Mental Health and Wellbeing Act, which is HR 7666. So that one's really exciting to see. I believe they're going through amendments as we speak. It'll be interesting to see what they include. We're hoping to have some 988 provisions included, but again, we'll have to see where the markup ends up. And otherwise, we're looking to the Senate Help Committee. We're hoping for their reauthorization soon, and we'll have to see how it aligns with the ENC version. And otherwise, we're tracking other 988 bills, hoping to see the markup for the skinny 988 Cardenas bill shortly. We don't have a date yet, but we're keeping an eye on it and looking forward to that. Thank you, Lindsay.
Fantastic. All right, and let's go from the federal government to the state perspective. So Steph, you want to kick it off, and then Jordan will go to you.
Yeah, thanks, Lindsay. So no changes to the map this week, but I think I wanted to take a moment to focus in on Nevada. So we, don't want to just see states pass good laws. We also want to see the follow-through implementation work out effectively. And so folks may remember last year, Nevada passed Senate Bill 390. And now that is moving into the regulatory phase. And actually this Friday, there will be a hearing on the telecommunications fee that law created. They are looking to actually charge the full amount of their fee at 35 cents to help build out their system. So if you are Nevada based, definitely encourage you to check that out, voice your support in written or oral comments. I will put a link to that hearing in the chat, and I'll turn things over to Jordan for a couple other general updates.
Yeah, thank you very much, Steph. Hope everyone's doing well. So just very, very briefly, 2 quick updates. Just want to say, one, that we're tracking Minnesota. Their session is finishing up, I believe, next week. So we're tracking some omnibus healthcare spending bills there that could potentially include some 988 funding. And just the second update, we're still kind of monitoring the situation in Kansas. They have a bill that passed the House there that would include some 988 money. That bill still needs to move past the Senate, and they have about a week to do that before their session ends. So those are just kind of the two things that we're keeping an eye on. And that's about all I have. Thank you.
Great. Thank you. Thank you both. And we had a question in the chat about how to get information on the June 22nd meeting around crisis services for individuals who are deaf and hard of hearing. And as always, that's going to be available on the this call, and you can sign up, get access to that information on the talk.crisisnow website. So I wanted to flag a couple of things here as we come to the back of the call, and maybe actually before we go to the tools, I just want to remind folks about the state cards that are out there. You can see kind of how states are moving forward with some actions to get ready for 988. And if we have any folks from Washington or Nevada or Virginia, a couple of the states that we have cards for, if they want to just provide a quick update, you're welcome to jump in and just share how things are going in your state.
Well, this is Tina Orwell, state representative from Washington. And no, we have all of our planning groups moving forward. And I was so excited today because we are bringing our 988 and 911 folks together. And we're looking at cross training and maybe co-location. And so again, just really excited about what the other states are doing. The other thing we're trying to tackle is around next day appointments, not only from Medicaid, but also from private insurance. And so again, those are big things on our plate, but I'm just really proud. We had this amazing trip to Arizona, which I want to thank RI staff, and we came back energized and ready to work. So thank you.
Yeah, that's a really interesting point around the next day appointments. I know something we've been grappling with more globally in Medicaid is workforce shortages, right? So how do we kind of meet the need in a timely manner when we're grappling with workforce shortages? So we'll look to you guys and see what you come up with, but I know that's it's such an important area. All right. Great. So also wanted to flag and remind folks that the calculator is out there to look at funding for this work. So Paul, do you want to jump in and say anything about how folks can use that tool and access that tool?
Sure, happy to do it, Lindsay. I'll tell you, last time when we chatted, I talked a little bit about how you could edit drive times as you're starting to project out how many mobile crisis response teams you really need for your communities. And one of the things I wasn't really able to lean into was that when you get into the calculator itself online, you actually have to select a county or a parish to get there. I don't know if I'm able to share my screen. Is that possible to do a quick little walkthrough? Oops. Is that, Karen, do you have your screen up?
Yep, looks like David has his screen up with the calculator.
David has his up. So David, if we could go in and just select a state, pick one there. We may, I'm not sure if everyone can see that. It looks pretty small, David. But once we select a county and you go in, what you can do is go down a little bit, and in your left-hand column, you're about to see drive time there. And again, a little bit hard to see on this screen, but what it will do is it will set the drive time based on the population that you're seeing in that county. It's projected based on the size of the area and a number of other things that McKinsey's been able to pull together, but you can edit it. So if it says your drive time is 20 minutes in that county, and you say, nope, traffic, everything else for us, it's 40 minutes typically. What's going to happen right next to it? It's going to change the number of episodes you would expect a team to deliver for care in a day. That then changes down below the projected number of teams and of course your cost for implementation. So again, the big tip for today is that get into a county or get into a parish. That statewide, it rolls it out, everything up. But you can go county by county and really get the details of what's going to work for that community. And I think that's a real vital resource. And as we saw Preston lean into before, micropolitan, rural, frontier areas, if you're not fine tuning these, it's going to be really challenging to meet the needs of that community. And so drive time is one of those influenced by mountains and a number of other things, of course.
And Paul, that might be a helpful thing as folks are looking at, what they're putting into spot, right? The standards that they want to have in place for mobile crisis. If you want to set those standards high, right, it may add a little bit of cost because you're with that. So yeah, great addition. Thank you for pointing that out.
Sure. Thanks, Lindsay.
Awesome. Okay. So just a few other items to flag as we come to the top of the hour here. Episode 5 of Moving America's Soul on Suicide is now available, and there's a number of other episodes in the pipeline. So encourage you all to check that out. And then our final slide is what's coming soon. So we already heard from Megan that on the 22nd of June, we are going to revisit the topic of crisis services for individuals who are deaf and hard of hearing. So we'll hear from Holly Ryu there. But in the next couple of weeks, we have some great topics lined up. Dr. Tom Insel is joining next week. As many of you know, he has a new book out. I'm sure many folks on this call have read it. And then also on June 1st, we're going to hear from Dr. Carol Olson about comorbid medical challenges and crisis, which we know is a key area of importance as you think about responding to behavioral health crises, understanding and assessing those medical, physical health needs as well. So make sure you mark your calendar, make sure you're receiving the newsletter and the updates so that you can stay plugged into those calls. And of course, on July 13th, we have 988 going live and Dr. Miriam Delphin-Rittman joining to talk on that call. So with that, I will thank everybody and give you back a couple of minutes of your day. And Karen noted in the chat that they're always looking for future Crisis Jam suggestions. So if you have a topic that's not on here that you want to see covered, please feel free to let Karen and the team know. So thank you guys so much for joining the Medicaid Bonanza today. And we'll see you next week, same time, same place.